Guys, welcome back. I would like to introduce our last speaker of the day, Dr. Samji. Dr. Samji is an endocrinologist with Norton Community Medical Associates at Norton Healthcare. He earned his medical degree from the Rashur Institute of Medical Sciences in India, and he completed his residency in internal medicine at Hurley Medical Center in Flint, Michigan, and his fellowship in endocrinology, diabetes, and metabolism at Virginia Commonwealth University. He's a member of the Endocrine Society and the American Association of Clinical Endocrinology, and he specializes in general endocrinology and diabetes cares. Welcome, Dr. Samji.
Good afternoon, everyone. Today I'm excited to talk about what's on the horizon in type 2 diabetes. We are in interesting times now when it comes to diabetes care, and with the new medications, GLP-1 and SGLT2 inhibitors, the management of diabetes has changed. And I'm going to be talking about what are the new medications in line, also be touching upon diabetes technology and procedures that are upcoming that we are all excited about. Before looking ahead into what is new in diabetes, I want to take a brief moment and look into the history of diabetes medication. Diabetes is an ancient disease, and before any of the medication, it was just treated with starvation and herbal supplements. And it all changed in 1922 when the first exogenous insulin was administered to humans. And the next change came around in 2008 when FDA recommended that any diabetes medication that has been approved should have cardiovascular safety. That's when we got new medications like SGLT2 inhibitors and GLP-1 receptor agonists that came about. And things are going, pretty interesting in that arena. And before going into future medications, I want to take a brief moment and look into the current diabetes recommendations by American Diabetes Association. Trying for the slide to go to the next slide. Looks like my computer is stuck. Sorry about that. Okay, there it is. So this is 2025 standards of care from American Diabetes Association. And when I was in med school, the initial treatment that I was taught is metformin. And then we add subsequent medications like glipizide, like Januvia and insulin, depending on the A1C control. And since 2018, things have changed. And going over this recommendation, the first thing that ADA emphasizes is to go over the health and lifestyle modifications. And that is the main thing that we all have to do initially. And when it comes to pharmacological therapy, the first line of medication is dependent on patients' risk factors. Do they have cardiovascular and kidney complications from diabetes? Do they need weight reduction? And the first line of choice for pharmacological therapy is dependent on that. If the patient has ASCVD risk factors, or if they have established diagnosis of CAD or heart failure, the first line of medication would be either GLP-1 receptor agonist or SGLT2 inhibitors. And if the patient is already on either of those, let's say if the patient is already on SGLT2 inhibitors, then we should consider adding a GLP-1 receptor agonist in those situations. And this recommendation is from the trials that showed that these medications would help patients in reducing the cardiovascular risk and progression of CKD to end-stage liver disease. And the same thing with the heart failure. If they have heart failure, the first line of diabetes medication that is recommended is SGLT2 inhibitors. The new trials that came about, semaglutide, did show that it also reduces the hospitalization with recurrent heart failure in patients with diabetes and obesity. And the SGLT2 inhibitors delays the progression of CKD to end-stage kidney disease requiring dialysis. And the same evidence is there for all GLP-1 receptor agonist. And when it comes to if the patient's main goal is obesity, if they are struggling with weight loss and they do have diabetes, the first line of medication that recommend is a medication that also has weight loss benefit along with A1C risk reduction. And when it comes to those medications, we all know that metformin and DPP-4 inhibitors like Januvia, they are weight neutral. And then comes the SGLT2 inhibitors that are intermediate. Patients do have weight loss with SGLT2 inhibitors, and in terms of percentage, it can vary anywhere from 1 to 2%. And the very high efficacy medications includes the GLP-1 receptor agonist, that is the semaglutide, tirzepatide, and duraglutide. And going back from the previous recommendation, the current standards of care is moving towards the precision medicine. It's not that one size fits for all. We have to consider what are the risk factors that patients have, what are the micro and macrovascular complications that they have, and choose the medications accordingly. Since we've established what's the current standards of care in treatment of diabetes, let's dive into what are the new medications that are coming up in the pipeline. Before that, brief look into what are GLP-1 and GIP medications. Now, these are the hormones that are part of the incretin system, and they're produced by the gut epithelial cells in response to the glucose ingestion, and GLP and GIP exerts their effects by binding to their specific receptors. And once secreted, these hormones are degraded by dipeptidyl peptidase 4, that is DPP4. And the drugs that are based on the GLP-1 and GIP system are the GLP-1 receptor agonist, GLP-GIP dual agonist, and DPP-4 inhibitors. And they do have various effects on various organs. For example, working on the pancreas, they increase the insulin secretion and decrease the glucagon secretion, especially the GLP-1 receptor agonist. Working at the gut, stomach, and the intestines, they do reduce the gastric emptying. Working at the central nervous system, they do decrease the appetite and decrease the caloric intake. Working on the adipose tissue, GIP especially increase the triglyceride uptake and the triglyceride storage. And working at the kidneys, they do reduce the sodium excretion. And it is due to these various effects on multiple organ systems. They do have various beneficiary effects on the cardiovascular health and on the kidneys and weight reduction. So let's look into what's new in this incretin world. The three new medications, or the main ones that I'm talking about, includes the CagriSema, that is the amylin and GLP-1 dual receptor agonist, retatrutide, that is actually a triple agonist, which includes GLP, GIP, and also glucagon receptors, and the oral non-peptide GLP-1 receptor agonist. And these medications are not FDA approved yet, as in they are still ongoing research, but they all have had at least phase 3 clinical trial, except for the retatrutide, wherein the clinical trial results will be out sometime next year. But the initial trials that has been published looks pretty promising, and we're going to go over the recent trials with each of these medications. The first medication I'm going to be talking about is CagriSema. Now, it is a combination of two medications, amylin and a GLP-1 receptor agonist, that is the semaglutide. Now, amylin is a hormone secreted by beta cells, and as a monotherapy itself, in the clinical initial trials, it is shown to reduce blood glucose levels, and it is taken once a week. And the new medication, the CagriSema, is a combination of the amylin and also the semaglutide, which is administered once a week. and redefined 2 trial. It's a phase 3 clinical trial, which included close to 1,200 subjects, and they did look into the effects of the cargisema in reduction of A1C and also body weight, and compared it to placebo. And going over the brief demographics and clinical characteristics, we do see here that the mean age is between 55 to 56 years of age, and the mean BMI is 36.1. So they did have patients with obesity, which was actually one of their inclusion criterias. And the mean hemoglobin A1C is 8.0%. And their inclusion criteria was patients with A1C greater than 7% and less than 9.5%. And they were on standard diabetes medications. And as we could see here, they are pretty well distributed in both the cargisema arm and the placebo arm. And when it comes to the results, the striking thing, the first thing is the A1C1 reduction. As we could see here, I'm going to go over each of these graphs. The first one is here, which showed that there was mean reduction of minus 1.8% in hemoglobin A1C compared to minus 0.4 in the placebo arm. Now, in the placebo arm, patients were treated as standard, diabetes, management, including medications and also lifestyle modifications. So even with that, the cargisema did show that it had minus 1.8 reduction in percentage reduction in A1C, which is actually comparable to the other GLP-1 receptor agonist trials. When it comes to weight loss benefit, now cargisema by itself had close to minus 13.7 weight reduction in terms of percentage compared to minus 3.4 in the placebo arm, which is again pretty significant. Some of these patients did have continuous glucose monitor. And if we look at the baseline here in the treatment or the cargisema arm before the trial, 43% of patients were at goal, that is blood sugar between 180 to 250. And in the placebo arm, it was 41%. And after the treatment, we saw that at goal blood glucose was 86.8% in the treatment arm compared to 50.2%. So that's a pretty significant improvement in the blood sugar target. And the other thing that we also look at is the percentage of patients who achieved A1C less than 6.5%. Going back, all the mean A1C was 8.0%. So 73.5% of patients in the cargisema arm had less than 6.5% A1C compared to 15.9 in the placebo arm. So this trial pretty much demonstrates that the cargisema is a good medication in reduction of A1C, in reduction of body weight. The GI side effects were pretty common. Reported side effects that was seen in 72% in the treatment arm. And again, the GI side effects are pretty common in GLP-1 receptor agonist or incretin-based medication as a whole. And they were reported to be mild to moderate GI side effects. Now, going to the second medication, that is the retatrutide, which is a triple receptor agonist. This is a phase 2 trial. Now the results for phase 3 trial will be coming out in sometime between March or May next year. But this phase 2 trial looked into multiple dose formulations of retatrutide and compared it to dulaglutide, which is a standard of, which is one of the GLP-1 receptor agonist. And I know this table is pretty busy, but what I want us to look into is the red bar graph here represents the dulaglutide, And in this arm, the inclusion in this trial, the inclusion criteria was pretty similar to what we discussed in the previous clinical trial, wherein A1C between 7 to 10%, body mass index more than 25% was their inclusion criteria. And as we could see here, that A1C of less than 7% was reached in the retatrutide arm, and this green graph here represents the highest dose, that is the 12 milligram dose of the retatrutide. This represents the 8 milligram dose, and they both had higher percentage of patients with A1C less than 7% compared to the duraglutide, which is Trulicity. And even patients had reached A1C of less than 5.7%. When it comes to reduction in A1C, the highest dose, that is the 12 milligram dose, had patients reduce their A1C close to 2% compared to 1.5% in the duraglutide arm. So overall, the medication at higher doses, that is 8 and 12 milligram, was actually superior to the duraglutide. The side effect profile was similar to other GLP-1 receptor agonists that we know of, including GI side effects, including nausea, vomiting, diarrhea, and constipation, although the side effect frequency increased as the dose of the duraglutide went up. The phase 3 trial will be coming out pretty soon, and it will be interesting to look into what the results would be. Now, one good thing this trial also included is actually the effect of retaglutide on the cholesterol, and it did show significant reduction in the non-HDL and the triglyceride levels, which translates to reduction in cardiovascular risk. The third medication that I'll be talking about is a oral GLP-1 receptor agonist. Now, right now, we do have an oral GLP-1 receptor agonist, that is oral semaglutide. Now, this is an oral GLP-1 receptor agonist too. The difference would be the semaglutide is a peptide in the sense that it has to be taken in empty stomach with water only, wait for 30 minutes before taking any other medications or food. Now, the orforglipron is a non-peptide wherein it could be taken any time of the day. And this is a trial that looked at the orforglipron at 3 doses, that is 3 milligram, 12 milligram, and 36 milligram as a monotherapy compared to placebo in adults. And the trial included patients with A1C of 7.0 to 9.5%. That was their inclusion criteria. And in this trial also, they included patients who have higher BMI. And as we could see, the BMI mean is 32%. So it looked at both reduction in blood glucose level and also looked into the weight loss benefit of the medication. And as the trial data shows, at 40-week mark, A1C decreased significantly from baseline in the orforglipron group and dependent on the dose. Patients who took 3 milligram dose had A1C reduction of minus 1.24%. As the dose increased, their A1C reduction went up to minus 4.7% in 12 milligram dose and minus 1.4% in 36 milligram dose. I'm sorry, it was minus 1.47 in 12 milligram dose. And compared to placebo, they had A1C reduction in minus 0.41%. And when it comes to weight loss, the percentage reduction in body weight was minus 4.5% in 3 milligram dose. And as the dose escalated, it went up to 5.8 and 7.46 reduction compared to placebo when it was just 1.7%. Now, one of the drawback of this study was they did not compare this medication to any particular medication as such, wherein the patients in the control arm were not on any medication. So they do have another ongoing trial which comparing the orforglipron to patients taking once a day Lantus, that is an insulin, and looking into what would be the A1C reduction would be in that situation. And also, it's only a 40-week trial. The phase 3 trial that they're doing is supposed to be 104 weeks. So we'll have data coming up pretty soon. But compared to oral semaglutide, that is the Rybelsus, the data in terms of A1C reduction and the weight loss benefit is pretty similar. And the GI side effects are again the most common side effects that we do see in this trial. Now, and again, these are not the only medications that are coming up in terms of medications for diabetes. There are a lot of studies looking into other incretin-based medication, but these are the ones that are ahead in terms of having phase 3 trials with promising results. Now, let's switch our gear. Let's talk about diabetes technology. And this is something that has been moving pretty fast when it comes to continuous glucose monitors, which has been so helpful for our patients in monitoring their blood glucose level, in making that healthy dietary choices, in tracking their therapeutic response in real time, and also getting real time data on low blood sugar and adjusting the medication. It has been a game changer for all of our patients who have diabetes and have been using continuous glucose monitor. And the most commonly used, again, FDA-approved CGMs that we have in United States includes Dexcom system, Libre system, Eversense, and Simplera Sync. And these continuous glucose monitor stick to the skin, onto the skin, and depending on the system, like Dexcom lasts for 10 days, Libre lasts for 14 days to 15 days, depending on which system we are using, and Simplera Sync for 15 days. The Eversense system is actually an implantable CGM, wherein there would be a sensor that is implanted every 6 months. There is a newer version of it that is Eversense 365 that could be implanted for 365 days. And all of this CGM, depending on which one, works with one of the form of continuous glucose monitors. Now, this is again something that has made in the world of diabetes. Continuous glucose monitors have been growing pretty fast. As you could see on the left side, this is how the initial continuous glucose monitors look like when they were being studied. And as you could see on the right side, how compact that they have become. Imagine our patients walking around with the older version of continuous glucose monitors. And these continuous glucose monitors work with the Dexcom, or works with the continuous glucose monitors, works with the insulin pumps. And the way they do is patients would have a continuous glucose monitor on their skin, and the pump. They would be communicating with each other, meaning the CGM would send the glucose level data to the insulin pump, which has an algorithm, and depending on the insulin blood sugar level, the insulin would be delivered. And this kind of system is what we call as closed loop, hybrid system. And whenever patients are consuming food, they would enter the amount of carbohydrates that they would be consuming. That's when the pump, based on the algorithm and the settings that we have set, will deliver insulin for the meal to correct for their blood glucose levels. And in world of the insulin pump, right now the main insulin pump systems that we have in the United States includes the MiniMed Medtronic, Omnipod, iLet Bionic Pancreas system, Tandem, and Twist. And all of these systems, they do have a hybrid loop, which would connect with one of the continuous glucose monitors. And the new development is the pump system have been updating their software so that it could be used universally with any of the available continuous glucose monitors. In terms of few differences onto the different pumps, the Omnipod pump is a tubeless pump, and the Mini Medtronic bionic pancreas and the Tandem and the Twist, they do have tubes along with the insulin pump. And as I said, they all work as a hybrid loop. One of the difference with the bionic pancreas again is the patients do not have to do the carbohydrate counting per se. They will have to enter what kind of meal that they are consuming. That way, the pump algorithm would calculate the carbohydrates based on their history and deliver the insulin. This is brief data on or graph on what happens behind the scenes when patient wear an insulin pump. As you could see on the bottom here, this is what we call as basal rate, and the insulin pump would be delivering insulin every hour based off of the blood sugar data that it gets from the continuous glucose monitor. And one good thing with the hybrid loop is if the blood glucose level are dropping below the target, the algorithm would kick in and try to deliver less insulin to maintain the blood sugar level at a target range. And if it starts to go above target, it does some micro bolus, is what we call, that is the extra insulin that the pump gives to bring the blood sugar down to the target. But again, patients do have to enter their carbohydrate or correctional boluses if needed. And this is the blood sugar data that we could see, the green graph, and the red are when the blood sugar goes below the target. And let's say, for example, here the patient is having food, they would enter the carbohydrate and the pump would give the bolus that would get the blood sugar down. So the evolving thing in diabetes technology includes making the continuous glucose monitors more accurate, more user-friendly, and to be able to use with any of the insulin pumps. And the algorithm have been getting better and better in terms of insulin delivery and making sure that the blood sugar control is obtained uh, more consistently than not. When it comes to the insulin delivery system, there has been ongoing research, but overall, the most commonly used insulin delivery is through subcutaneous injections, either through vials and syringes or through insulin pen. The Afreeza, again, it's not a new medication. It is a newish and compared to the insulin pen, but it has been approved by FDA in 2014, and it is an inhaled rapid-acting insulin that could be used in patients who have needle phobia or who cannot take insulin medication consistently. And the smart insulin, again, is ongoing research into that. And what it is, smart insulin means the insulin molecule would be bound to the protein, and once administered would be delivered according to the blood glucose level. And this technology is again in very primitive stage of research. And currently they're looking in research into the animal models right now. But again, this is something that we might see sometime in distant future. Now, when it comes to surgical procedures, now bariatric surgery has been one thing that has shown to reduce weight and also reverse diabetes. And a lot of, again, research has been ongoing into incretin system and trying to alter the system through surgical procedures. And the whole idea is patients would have duodenal mucosal dysfunction, which is where the cells that would produce the GLP one would be present, that is in the enterocyte and endocrine cells. They would be thickened duodenal mucosa that would lead to less production of those incretin hormones, and procedures like duodenal mucosal resurfacing, wherein they would inject saline to lift the mucosa and do a hypothermal ablation to alter those cells so that they would increase the GLP-1 receptor, has been ongoing. And again, this has been studied initially in 2014, which showed that the patient would have a reduction in A1C of close to 1.2%. But since it's an invasive procedure and we do have medications that would reduce A1C even much more, much better than the procedure, it has not been widely used, but the research is ongoing to look into more safer techniques wherein patients would have less side effects, more reduction in A1C, or sometimes repeat the procedure. That way they could have sustained reduction in A1C. This is something that is ongoing in the surgical front. So to summarize, what's coming up next in the diabetes world, the treatment modalities have been again moving more towards precision medicine, more towards individualized approach rather than one size fits all. It's moving towards not just control of diabetes or blood sugar, but also trying to address the complications that would happen with diabetes, that is micro and macrovascular complication, and looking into the treatment choices that would improve their quality of life, reduce the complications, and again, emphasis on lifestyle changes, dietary changes, whenever we see that patients have hit a plateau in terms of their diabetes improvement. So that's pretty much about the presentation as to what are some of the newer things that are ongoing in terms of diabetes management. If you have any questions, please feel free to ask me, and I've included my email ID. You could also email me if you have any questions.
Well, Dr. Samji, I have a question, and it goes back to the CGMs, the Eversense. So my question is, do you have any patients who have used the Eversense CGM? And if so, what's the experience been?
I do not have any patients actually who are on Eversense, and I guess one of the main reason has been uh, the Dexcom and the Libre or any other CGM, which could just be changed every 15 days. Works so far, has been working well for the patients, but yeah, I don't have anyone yet.
Awesome. Well, thank you so much for your time today. We greatly appreciate